So Sarah, I want to ask Sara, because Sarah's been quite involved with abemaciclib, I know in the preoperative setting, but in the Monarch 1 data, very nice late line data as monotherapy higher dose. Would you ever use that, do you think, in practice, or are we going to basically everybody's going to get CDK up front with endocrine therapy?
Well, women live so long, fortunately, with this disease that I do have a number of patients who are eligible for this monotherapy, namely patients who've been treated with a line or two of chemotherapy, which was the design of Monarch 1. And patients who've exhausted all other endocrine options, aromatase inhibitors, fulvestrant, for example. I think it's a good option to try. I don't use it in patients who have been pre-treated with another CDK4/6 inhibitor and have progressed. I've seen that happen in other practices, but I don't condone that. That's not how the study was done, and I think those patients really should be going on clinical trials to address how do we treat patients who have been exposed to and are resistant to CDK4/6 inhibitors. But I think the tolerability is pretty good. You are able to use this higher dose, the 200 milligram BID dose. You still have to watch for diarrhea and cytopenias in about a quarter of patients. But at the median follow-up of about 18 months, the median overall survival was almost 2 years, 22 months. In a pretty heavily pretreated patient population. So I do think it's impressive data, albeit phase 2 data, but impressive data supporting its use in heavily pretreated patients.
Yeah, and compared to our other options, it looks very good, compared to chemotherapy, has shorter median PFS and shorter overall survival, cross-study comparison. But yeah, the data look good for those who haven't had a CDK4/6 inhibitor.
It just seems so unlikely that we're going to find a group of patients who received multiple lines of endocrine therapy and chemo and haven't had a CDK4/6 inhibitor.
So it's going to be our long livers, that are our 5+ year patients, who are way out there, et cetera. So there's a small subset, but so lots going on in the CDK4/6 world. But then we come to Everolimus, Komal. Do you still use Everolimus in your practice? What do you think the role of it is?
I do. I know we all, as a community, are very disturbed about the mucositis rates and all the side effects that we see from Everolimus, but I do land up using a lot of Everolimus still in my practice. And with the data now emerging with fulvestrant as a partner with Everolimus, I think it has been more compelling in some ways to think about Everolimus yet again, just outside of the exemestane Everolimus from the Bolero-2 data that we've been utilizing thus far. I also use Everolimus with tamoxifen based on the TAMRAT-2 trial, and I do think that there is data that even in the ESR1 mutants, tamoxifen could have some role. So I feel like I kind of use that as an excuse to use tamoxifen with Everolimus in certain patients. And now with the PRECOG study that has now been published in the JCO this year, that looked at the combination of fulvestrant with Everolimus and showed doubling of the progression-free survival. So 5 months to 10 months. I thought that was very impressive. What also caught my attention actually was very interesting from the MANTA trial that Peter Schmidt presented last year. The MANTA trial was outset to look at vistasertib, a TORC1, TORC2 inhibitor. And while they couldn't show any benefit for that compound, the control arm, where they looked at fulvestrant Everolimus, that combination had a PFS of 12.4 months compared to fulvestrant alone of 5 months. What we don't have, like we don't have with everything else, is post-CDK4/6 does this hold true. Having said that, I think it's certainly something that we use in practice even now until we get this data of what happens post-CDK4/6.
Yeah.
The one thing I will say is in that study, the PRECOG study, which I think really does support the use of fulvestrant in combination with Everolimus. They didn't, because they started the trial before we had the data from the dexamethasone mouthwash called the SWISH study, which is now on the Everolimus label. They didn't use the mouthwash. And, they saw the expected stomatitis rate, which is quite high, with an up to 8-9% grade 3. And with the mouthwash, we of course have eliminated grade 3
Absolutely agree.
stomatitis, and we see that in practice. Really, I think it wasn't just the phase 2 study. And Joyce, of course, you've done a study showing very similar data. So I think that we can think about the toxicity in a slightly different way. Of course, we still see some of the other toxicities from everolimus, but much less than we did before.
Yeah,
Right.
and I'm not seeing that much pneumonitis with the Everolimus. I mean, it's reported it's a very small, but it's low single digits basically for people that are on it quite a long time. But I think we're all much more aware of it. We're aware of that cough and shortness of breath to get that CT scan. So we can manage that. But a lot of people, they'll use serial endocrine agent CDK4/6 and then go on to capecitabine. You know what I mean? And should we think about everolimus, instead of capecitabine?
So that's a very important question that was actually set out by the Bolero 6 study. So we have many Bolero studies now, and the 6th Bolero study looked at a 3-arm comparison, and the patients were randomized to either getting the combination from Bolero 2, which is exemestane with everolimus, versus everolimus alone. I think the only study that has some data for everolimus alone versus capecitabine. The primary endpoint, though, for this Bolero 6 trial was to look at the hazard ratio of progression-free survival comparing exemestane everolimus with everolimus, and that was 0.7. So it does show and makes sense that, okay, the combination, we know that from PI3K inhibitors, that endocrine therapy in combination with PI3K inhibitors is better than PI3K alone. We saw that with this primary endpoint. The secondary endpoint was to look at the hazard ratio of PFS for the Bolero regimen, the exemestane Evero, with capecitabine, and very important question that we want to look at in clinic. The hazard ratio there is 1.26. But the capecitabine arm might have been favored because of the imbalances in the baseline characteristics of that patient population. Fewer patients in the capecitabine arm had less or more than 3 metastatic sites. More patients had chemotherapy in the exemestane everolimus compared to the CAPE arm. So there were more visceral metastatic sites that were seen in the everolimus group compared to the CAPE group. More bone metastases in the CAPE group. And perhaps that could have been reason that we see the hazard ratio as such. In clinic, I think we'll end up using Xeloda or capecitabine after the endocrine therapy manipulations as perhaps the first treatment option for most patients, unless we're thinking about a taxane.
But it's interesting. I do think that if you just compare them side by side, Paloma was one of the few studies, Paloma 3 was one of the few studies that reported how patients did after treatment.
Right.
And when they looked at the different options, of course, this was up to physician and patient choice, but the longest PFS was actually with capecitabine, and the shorter PFSs were with endocrine therapy. But one general statement that I think is important in practice for all of these hormonal bio combinations, and Hope alluded to this earlier, you have to have some degree of intrinsic hormonal sensitivity. So if you enroll patients with very low ER content, those patients aren't going to do as well. If you enroll patients who we may not know this at the time, but actually are not luminal A or B, they won't do well, and that has been shown as well. So that's a very important point to make. And secondly, it is important to, if the patient still is hormonally responsive, you need to block both of the pathways, the escape pathway and the endocrine pathway. For example, with HER2 mutations, most of them are ER positive. When you use a neratinib, for example, the results are going to be better if you also use fulvestrant or some hormonal blockade. And so this is a general principle that we need to follow in this strategy.
Which is really, I think, quite intriguing.
It's very interesting, and capecitabine or everolimus exemestane, we're going to probably use them both, you know what I mean? And, which exact order, but it is intriguing that CAPE, which is an S-phase agent, after a G1 S-phase agent, CDK4/6, works like a champ, you know what I mean? But everolimus exemestane also, in the Paloma 3 trial also had some benefit in the patients
They all
after
seem to benefit.
CDK4/6. So we just don't. We need more data, certainly.
need
But
more data.
it's kind of an individual patient choice. We're going to use them all eventually, I think.
I think